Greetings, this is Dr. Bill White again with the American Orthodontic Society, and I want to talk a little bit about adult orthodontics. In fact, I like to talk a lot about adult orthodontics. It's something that we have neglected and it needs to be met. And someone wrote back they would like to see more adult men that had orthodontic problems. So I'm trying to show several gentlemen that had orthodontic problems. Now this man, I worked with him for years after we got through. We just kept seeing him back and watching this case. And I'll go ahead and get started with him here. Let's see, I'll have to. Here he is. Now he came in not because of crooked teeth or anything that didn't look good, but he came in because he was in such pain. He was taking so much medication that he could hardly operate his job that he was doing, and he was having a problem with that. And so we went in and found out what was actually causing the problem. It was pushing, the jaw was being shoved distal against this retrodiscal tissue back here that's very vascular and is very sensitive. If you put a lot of pressure on it, it can give you a fit. And if you don't believe it, if you ever have it, you get where you won't let anybody touch you up here on the joint. So he came in with a lot of pain, and we found out what it was, and we went in orthodontically and corrected the problem, and the pain just went away. Now, I'm going to run through this rather fast, but I've got a full video on him earlier on, but let me just go through it. And I don't want to just make it look like a movie. But here is the gentleman, and I'm going to cover this pretty quick. They've got lots of pictures on it. Well, we've got a deep bite, and we have a tooth that's shoved out of place on the deal, the cross bite, and just a lot of different problems that we had with this case. And you see that bicuspid is completely off. It's missing it right here. And there's a tooth crowded out of the arch right in here. And the result of this closed bite in here was causing the jaw to be pushed backward, and the condyle was pushing against the retrodiscal tissue. And this part was extremely sore up in here, and he was having to take pain medicine just to put up with it. Now you watch, this is a cuspid position. We're going to move that over here, and it'll drop back in this place. When we open the bite, it's real crowded. We didn't take any teeth out at all. We're going to elevate these teeth. As they come up, they'll come forward like this and make some space in this area. And then his lower jaw followed the upper jaw, and as it did, the condyle back here in the back moved away from the retrodiscal tissue, and the pain subsided. And we kept him on the medication there until we got this out of the way. We had to pull it up. We put him in a splint also in doing this. Okay, let's get lots of pictures on. The other side of the mouth was nearly class 1. Class 1 would have been right down here. And it's almost in class 1. And this is one of the things where you're class 1, you've got a molar kind of coming in here. And this cusp of the upper first molar should come in contact with the mesial cusp of the lower second molar. That's one of the 6 keys to occlusion. And these teeth will be lined up down that deal. So this side of his mouth was in pretty good shape, but the deep bite kept this jaw forced to the back. Now, he is about, I think, 50 years old when we started, or 40 something. He's somewhere down here. He's 51 years old. So I'm gonna go ahead and go through them. Now you can see the lower anteriors went up and were eating away on the upper anterior teeth, and the whole jaw is kind of off to this side, you see, and that's where this was class 2. So I'm not going to get through there very quick. Now we had trouble getting this tooth through this line. We had to expand this arc, and I had to get the bite open first, and then as I opened it, these teeth moved forward, got these teeth out of the way, and we got enough room in here to take that tooth through there. But I used a big daddy arch wire and put a lot of force on it. It was putting these teeth against this one tooth, and it took it right through that space right there. Let me go now. Looking from the inside, its lower anteriors closed up against the tissue up above here. And here's that tooth on the inside. We had a crossbite in here, and one on the outside was in a crossbite out there. Now these are adult cases, and these are people who really need orthodontics. You could pull teeth and put splints and take medication and do all sorts of stuff. He'd been on medication so much that he could hardly keep his jaw. You're just putting a Band-Aid on a problem that's rotten out from the bottom. You need to go to the source of it, what's causing it. And the position of these teeth in here was making the jaw go back further than it wanted to go, and it's taking the condyle, which is in the socket here, shoving it back into this retrodiscal tissue that is highly vascular and produces all this synovial fluid and carries the food and takes away the waste from the jaw joint liquid in here that gives it. This is lubricated. I'm nearly, well, at my age, I've still got pretty good disc, and the thing is lubricated by this fluid in this joint. It is the most complicated joint in the body, and when it goes bad, I've had mine where you couldn't hardly touch it up here on the side. I don't want to spend too much time on the temporomandibular joint, but he had a bad case of it. And I followed this gentleman for about 10 or 12 years after we got through, just to see how this worked out. All right, here we went in. I will cover all the, if you want to go back in the first videos we put in, he's back in there somewhere, and it'll be slower, and we'll explain the mechanics of a lot of stuff. But we lowered those bites. When we raise this, we open the bite, and you use those intruding arches, and you raise them up, and pull this down, and you take this up here, and when you do that, these were crowded, and you see now we got a space in there. So we'll probably tie this together and open it a little further, and it comes up far enough where we can pull this tooth right here through this gap. Increase that space. Okay, let's see. Now I have to look down to punch all these darn buttons, but anyway, you get the idea. We did that, and just because this guy, I think he's 50 years old or something when we started, his teeth moved, the bone did not solidify where it couldn't move at all. This is just a bunch of bull that somebody came up with just because they didn't want to do this kind of stuff. You can do this work. This is necessary and people need to learn how to do it, and it ought to be taught in the blooming schools that teach our orthodontists how to do this. And now the ones that are doing it, I'm sorry to get irritated with the school system that we have in training people like this, but there's a lot of orthodontic schools, they don't even want to teach this. And so it's a lot of work. You have to charge a lot more for these cases, but there are people that really need it, and we got this guy solved, and I followed him for years afterward, and he's still know the guy. He wouldn't mind me using his name. You know, he is so glad to get rid of this pain that he was suffering from. And dentists, whoever wanted to do orthodontics, if you'd get in there, learn it, and do it properly, that's what I'm wanting you to do. And I won't be around too much longer to bug you, but I want to see something happen in this adult orthodontics. And this guy, okay, I'm going to run through this. And we put a big daddy arch wire, and we played all these teeth on this side of the mouth against this one tooth right there, and it brought it through that gap, even though it didn't have quite enough room. We should have opened the gap sooner. But anyway, that's the big daddy wire that we've come up with years earlier. And we can expand anybody walking and breathing that comes in the office. I don't care how old they are. I don't care anything. You can take a wire from the outside and expand it. And it's cheap. It costs nothing. And nobody's going to sell this and make a fortune off of it. You can buy a stick of this 014 or 36 wire and cut it in two. It makes two of these arch wires. And it costs it's almost nothing. And it'll expand any arch you put it on. I will guarantee you. And you don't want to really put a lot of expansion in it and let some idiot run off. It would have their teeth sticking out of their cheeks on the sides. So that's and it keeps it out of the inside. And it's so much easier to put on. You can use the upper, above, below. You can expand these teeth up here and leave these alone. Or you can expand these and leave these alone. You can expand any part of it. And on this particular case, we took this tooth right in here. Well, it was this one. We brought that tooth through. All the force is being taken up by this tooth right here. And it brought it in there. Now, somebody may gripe about that, but you can expand anything walking or breathing that is alive. I don't care how old they are. And if they'll just come in, if it's an ankylosed tooth, now you're going to have to go in. However, I think I could expand the whole bone out and carry the ankylosed tooth out with it. It'd be on the bus. You expand the bus, it takes everybody in it out. Okay, I'm going to run through a little faster here. And then we lined all the teeth up and did the orthodontic work just like you do on any of these cases. And these are adult men. I've gotten 3 of these cases today on here. We're putting on there. Adult men have the problem, but not near as many men as women. We have about 80% women and about 20% men had jaw joint problems. That's not really accurate. I didn't do any double-blind studies on this stuff. But anyway, that's about what it is. But you see where his lower teeth were biting into his upper anterior teeth, right in there, wearing that down. That shoved that mandible backward, and it pushed the head of the condyle into this retrodiscal tissue. And I've been harping on that for a long time. Now we've got a kind of a jaw that's kind of off at a turn, and you see where this cuspid is over here and the one over there, and we're going to have to come back around. So one of these jaw joints has a little crowded just because of the position of the teeth there. All right, here we go again now on the bottom, and we finished all of it. We had the lower anteriors were still in the brackets, and we get him lined up with a retainer. Now he wears a retainer, maybe too much. You see the track of it? But if he takes the thing out, this goes back and pushes on that tissue, and he's hurt. So he knows that. So I don't have any problem with him not wearing his retainer. I mean, he religiously wore it. He lost it or something one time there, and boy, we had to get another one in there for him. And I've watched him for 10 or 20, it may have been 20 years I've kept up with him. All right, we had a little ramp on there to pull that forward again. And this is that side that the class 2, this part was way out here somewhere. Now it's right in there. It slipped, if that's the place. It slipped back a little bit. All right, here he is. Now this is 1986. You'd have to remember where we started out there. Let me see, I'm going to have to go back. All right, that's 86. He's got his hair up through, and he's getting a little older, getting a little gray hair and his beard down here. And you can tell he's maturing. And then all of a sudden, he was losing his upper hair, and I didn't know it. And he went and got a wig. And I was kind of shocked me. He came in one time. One time I saw him, he had hair, and the next time he didn't. Now this is 1991. We were still in there. Now he lost all that hair, but he had a wig that he wore, and I thought that he aged like mad. But now he's getting older, 93. There he is now. No pain. We're staying in there with it. That's 82, 95. All right. This is 1982 to 95. So there's about 12 or 13 years in there. I've got pictures of it. Excuse me. But I watched him, I don't know, till I left. He still was coming in every once in a while, and I would see him. This was 1993 here. And there it was in this was 1982, and that was 93. That's the way the upper arch was. We still have a twist to that upper arch. But here is 82, and you can tell a deep bite. The lower teeth go up to here. And here is 44 years old. That's in 83. 83. 93. And go back. That's 93. 83 is 10 years after. No pain. Okay. This is an adult case. This is not all that I got on this gentleman, but I know him as a personal friend now. I've kept up with him for so many years, and he came back in, and he has never had that jaw joint problem after we got his jaw where his jaw could come forward. So this is got temporomandibular joint, the expanding with the big daddy, the age, and all this in there. And I'm gonna quit right now and say goodbye for the time being. But adult orthodontics needs to be taught and needs to be done by officials that are trained in it. It's somebody just coming along learning it like I did may not have had the zeal to get after it and stay with it. And we had patients that were really in pain, and we could move their teeth around where the jaw could come out and give it some relief, and that stopped the pain. So I'm going to say goodbye and hope you'll pass this on. If you are having trouble and you go to the person who is straightening your teeth and they don't know how to do it, or they tell you, take them the blooming videos and let them look at it. We've got enough videos there to, I don't know, it's over 400 of them. And so hope you take this and use it, and let the price you charge somebody pay you enough to where you can stay in business. You can't do it at the price you do kids orthodontics, and that's a big mistake. We should have had, you fix my car, you give me an estimate of what it's going to cost, and then you do it. If you don't put a sign up there, cars fixed for $5,000. This is ridiculous to start with. Okay, so I'm going to say goodbye and thank you for watching, and I hope you get something out of this.